Assalamu alaikum. This is Dr. Mariam Al-Abdallah, a professor in orthodontics at the University of Jordan and a senior orthodontic consultant at the Jordan University Hospital. This is our second lecture on orthodontic assessment, and we will be covering the intraoral examination and further diagnostic records necessary. Chapter 5, An Introduction to Orthodontics by Simon Littlewood and Laura Mitchell, 5th edition. Right, so as you remember, this is part of collecting the data that is necessary to reach to a proper diagnosis and later on proper treatment planning for our patient. So we talked about history taking, we talked about extraoral clinical examination, and today we're going to continue with the intraoral examination. This should include the general condition of the mouth. And then we go to examining the lower arch alone, the upper arch alone, and then teeth in occlusion. So the relationship between upper and lower teeth in maximum intercuspation. And then we're going to talk a little bit about the diagnostic records necessary. Why do we need to go for intraoral examination? Well, this is important to assess the stage of dental development by looking at teeth erupted, deciduous teeth still there, look at the compare between the patient's chronological age and the patient's dental age. We need also to have a look at soft tissues and the periodontium, check for any pathology, any problem. We need to look at the general oral hygiene and the overall dental health, and this should include, of course, any active caries, if there's any restoration, the condition of these restorations, if we have any broken edges, recurrent caries, etc. And of course, this examination should include the tooth position in each arch and in between arches. So as we said, the general condition should include oral hygiene. So you need to have your examination form and you need to fill in the oral hygiene. Is it good, fair, or poor? You need to look at the general periodontal health for the patient. As we said, tooth quality need to be recorded properly, especially caries teeth, teeth of poor prognosis, if you have any enamel hypoplasia or a problem with the tooth, and quality of existing restorations. Why we're doing this? Well, because any active pathology related to soft tissues or related to the tooth has to be treated and settled before any active orthodontic treatment is started. Now, fortunately, most of our patients are children, so having periodontal problems is rare. But nowadays, number of adult patients are increasing because, society is more aware of aesthetics. They are more accepting the appearance of appliances, and demand of this category of patients has increased. So any adult patient should have a comprehensive periodontal assessment before any orthodontic treatment could be started. An excellent oral hygiene is a must before the start of orthodontic treatment, and selection of patients based on this is very important. Any problem detected related to the periodontium, related to the tooth, not only important to be settled before orthodontic treatment, but it's important to be properly documented, as this might affect our treatment plan, especially the decision related to extraction. So caries teeth, areas of hypomineralization, a tooth with a previous trauma, non-vital tooth with or without root canal treatment, tooth wear due to trauma, abnormality in size or shape, restorations, old restorations with or without any problems should be recorded, as this will affect our treatment decision if extraction is required. So this is an example of a patient with poor oral hygiene. So this has to be properly documented, and of course, later on after finish of examination, patient should be should have a proper oral hygiene instructions and scaling and polishing, and they should be seen several visits before we are sure that the patient could maintain excellent oral hygiene. This is a fair oral hygiene. These are some of the examples of patients with gingival recession. So this is very important feature to be documented. Temporary filling in the lower left 6, two surface filling in the lower right 6, temporary filling in the upper right 6, and an amalgam filling in the 5. Oh, we have also here hypoplastic 7 in the upper left quadrant. This is important to be documented. Badly destructed 6 in the upper right quadrant, lower left quadrant, poor 6, lower right one, filling and recurrent caries, etc. So these are important features to be recorded. A patient with hypoplasia, enamel hypoplasia, and a patient with poor oral hygiene and gingival recession affecting the lower central incisors. So we have here fillings. So after examining the general condition, periodontium, tooth quality, this has to be documented in your assessment form, and this is how it looks like. So tooth quality and caries check, you have to write here your what you saw inside the patient's mouth. Oral hygiene in general, fair, poor, good. Others related to, for example, gingival recession, pocketing, and then teeth present. Okay, so as you go for the general examination, you need to check and count teeth, and this is important. This step is very important. You should not overlook it at all. And we use the 1, 2, 3, 4 system for the permanent dentition and the ABCD for the deciduous dentition. And if you're going to talk about individual teeth, then you can use the palmarination method to specify your tooth. So this is an example of the lower arch, okay? We always start in the lower and we always start on the left side. So this is the left 6. This is a partially erupted 5. So you can see here the charting, okay? So this is a 6, this is a 5 partially erupted, 4, 3, 2, and then we have here an A, retained A. So we write it down. This is a retained A. And then on the lower right, we continue. This is a retained A. This is a 2, 3, 4, 5, 6. So this is how you chart your teeth present. Okay. Another example here. So we started the lower left. So this is the 6. You can see the charting here already written. So this is the 6. This is the E. This is a boy, 11 years old boy. So this is the E. This is a 4, 3, 2, 1. And then, as you can see here, we continue on the lower right. 1, 2, 3, 4. And we have here no E, no 5. So we have to go with a big X. Okay. If we don't write it an X, then sometimes you overlook that you have something wrong in this quadrant. Okay. Because we either have an E or a 5, or maybe because he's 11, this is the 5 is almost erupting, okay? But we have to go with an X if we have a tooth not erupted. And then the 6. In the upper left quadrant, you can see this is the 6. E, I don't say retained E. This is an E because the patient is 11, and this is what we see normally at that age. This is a 4 partially erupted. You can see the 4 partially erupted. And here, I'm not sure if this is a 3 or not, so we go with an X. And then 2, 1, and the upper right, we continue 1, 2. This is a C, and this is a 3. So I could say that this is a retained C in this case because the 3 is fully erupted in here. And there is no 4, no D, so we go with a big X. And then we have the E and the 6. Now, this is not normal. Having this in a boy who's 11 years old is not normal in terms of dental development and in terms of sequence of eruption and position. Usually the canine should erupt in the place of the deciduous deciduous canine, okay, not beside it. So there must be something wrong here. So an OBG is justified to be taken to know what's happening. So as you can see in this quadrant, we have the C, the canine, congenitally missing 4, we have the E, and we have no 5, congenitally missing 5. Okay? On the other side here, you can see this is the 6, this is the developing 7, this is normal, 6, and we have the E, and we don't have a 5, so this is congenitally missing 5 on the upper left quadrant. And we have the partially erupted 4 and the canine almost erupting. In the lower arch, everything looks normal, except for this 5 where we have delayed dental development compared to the other side. It doesn't look normal in terms of size and shape and in the dental stage development. Okay, so this is important to, this is how we document the teeth present. Now we look at each arch alone in order to assess crowding or spacing, alignment of teeth and displacement or rotation, inclination in the buccolingual direction, angulation in the mesiodistal direction, and then arch shape and symmetry and depth of curve of spine. To do so, it's easier to divide the arch into the labial surface, the left buccal surface, and the left and the right buccal surface or segment, sorry. And then in each segment, you need to record the things that we talked about. You need to record the teeth present, tooth morphology, space condition, malposition and rotations, inclination and angulation. So teeth present, for example, as we said, we need to count teeth, and it's important to document any abnormalities. For example, supernumerary tooth agenesis, impacted teeth, extracted teeth, delayed eruption, or retained deciduous asymmetric eruption. So let's take this lower arch as an example. Okay, if we have a quick look on this lower arch, we would say, oh, it looks normal. A little bit of mesial tip for this 4, mild crowding, a little bit of rotation, mesiolingual rotation of this 5, nothing of a big deal. But if we count teeth, which is the first thing you should do, we will know that there is something wrong. So this is the lower left, 7, 6, 5, 4, 3. And then we have 2 incisors, and then we have the 3, 4, 5, 6, 7. So we have 2 missing incisors. And as we know from the research and the epidemiological studies, that the most commonly to be congenitally missing are the lower central incisors. And this radiograph confirms that they are not impacted, they are congenitally missing. So this is the canine with its big root. These are the 2 lateral incisors, and this is the canine, and we have missing central incisors. So counting teeth is very important. This is another example in the lower arch. You can see that this is the 7, 6, 5, 4, 3, and this is the lateral severely crowded and severely lingually displaced. And then we have the central, and then in the lower right, we continue with the central, and then the lateral, and then a big X in our tooth present chart because we don't have a canine, and then we have a 4, 5, 6, 7. So it's important to count teeth, otherwise you will not have guessed that we have a missing canine here. So we need to take a radiograph to confirm and to confirm that it's not there. Well, it's not only impacted this lower right canine, but it has crossed the mid-sagittal plane. So we call this transosseous migration. So it is severely impacted with transosseous migration. Okay. This is related to tooth morphology. Okay, in addition to counting teeth here, you will notice that this lateral is not like the other one. We have a tail and cusp on this lateral here, so we need to document this. For this patient, we have a missing lateral on the upper left quadrant, and the upper right quadrant, we have the lateral microdontia, smaller in size relative to the normal. Here, the teeth are small, especially the lateral incisors. We call them big-shaped lateral incisors, but here you can see totally the opposite. We have a megatooth, or what we call macrodontia, affecting the incisors, the centrals, especially the upper left one. Now, in terms of space condition, you would either say well aligned or spaced or crowded. If you say spaced or crowded, you need to continue saying mild, moderate, severe. You will have a proper lecture on space analysis, but here I'm just going to tell you what to write on your assessment form. If you say well aligned, that means we have to have each contact point of a tooth is next in touch with the contact point of the next tooth, and so on and so forth, with all the teeth following a nice arch form. Okay, if this is the case, we say, oh yes, it is well aligned. Okay, if not, then we need to choose crowding or spacing. The space available is the length of the arch that the patient has. Space required is the mesodistal width of teeth that should occupy this arch. Okay, the difference between them is the space condition. So if I have more space available than space required, that means I will be having spacing. If I have space required more than the space available, that means we're going to be having crowding. As a general rule, crowding is classified into mild if it's up to 4 millimeter of crowding, moderate if it's 4 to 8 millimeter of crowding, and severe if it's more than 8 millimeter of crowding. So again, let's look at this lower arch. We have the lower left 7, 6, 5, 4, 3, and then the lateral is severely crowded, lingually displaced, and then we have the central, and then in the lower right quadrant we have the central, the lateral, severely crowded, lingually displaced, and the canine, severely crowded and lingually displaced, and then we have the 4, the 5, the 6, the 7. How do you describe this arch? Severely crowded. Definitely this is more than 8 millimeter of crowding. Okay, so this is severely crowded, V-shaped arch with a severely lingually displaced both laterals and the lower right canine. Now, this arch here, we count teeth. So this is the upper left 7, 6, 5, 4, 3. This is the lateral, severely displaced in the palate, severely crowded. And then this is the central on the upper right quadrant. And then again, the lateral is severely displaced palatally. And this is the canine, and this is the C. And we call this retained C. And then we have the 4, the 5, and the 6. Okay, so this arch from the space condition point of view is severely crowded with both lateral incisors palatally excluded from the arch and displaced. This is a lower arch with the lower labial segment well aligned, but the buccal segment with mild crowding. And this is the lower left 5. This is the distal contact point, and this is the mesial contact point. And we need to say that this is mesio-lingually rotated. You could say disto-buccally rotated as well, because it's both contact points are equally displaced. Here we have moderate crowding. This lower left canine is mesio-labially rotated. You can see that the mesial contact point is more severely displaced than the distal contact point. So the accurate description of the rotation of this tooth is mesio-labially rotated. Okay, and this is mesolabially rotated 4, and the disto-lingually rotated 3 in the right quadrant. Okay, and we have moderate crowding. This is a mild to moderate crowding. So this is a 1, 2, 3, 4, 5. So it's a 5. So it's a moderate crowding. Let's say it's a borderline between mild and moderate. Anyway, with multiple rotations. So you can see this lateral in the upper left quadrant is mesio-labially rotated. Okay, this central incisor is mesio-palatally rotated. And this canine is buccally displaced. So this is how you describe the arch. This lower arch is spaced. So we have generalized spacing, mild generalized spacing. This is mild generalized spacing as well. This is more a moderate generalized spacing with multiple rotations. This is severe generalized spacing, and you can see the etiology. It's a generalized microdontia with congenitally missing central incisors and retained Bs. Now, malposition. Now, it's important to look at the position of the teeth, like we just described, if it's erupting within the line of the arch, or if it's displaced palatally, or lingually, or buccally, or labially. Okay, this has to be mentioned. Like these, both laterals are severely displaced palatally. As we said in the rotation, this arch, of course, is severely crowded. This, for example, this canine on the upper left quadrant is buccally displaced. This four in specific, you would say that this is an esio-palatally rotated four. Okay. Now, the inclination is to describe the buccolingual position of the tooth. And if we look at the upper teeth, we compare the position of the upper teeth to the Frankfurt plane, and we compare the position of the lower teeth to the mandibular, lower border of the mandible, okay, mandibular plane, because this is a clinical examination. Otherwise, if you want to have a more accurate assessment of teeth inclination, we have to take a lateral cephalogram and go for a proper analysis. Okay, but clinically, you could see obviously that the central incisors here, for example, are retroclined and the upper laterals are proclined. So this is how we describe the inclination: average, proclined, retroclined. Now, in terms of the angulation, we describe the mesiodistal tip, and we would say either the tooth is upright or mesially tipped or distally tipped. If it's normal, we don't have to mention that in our assessment form. So here is a normally angulated canine. A little bit of mesial tip is normal. This is a canine that is upright, and this is a canine that is distally tipped. And this is important if you want to assess anchorage, movement of teeth, etc. Now, everything we talked about in terms of lower arch alone, upper arch alone, should fit in this part of the examination form. Okay, so alignment and space condition, that includes teeth present, tooth morphology, space condition, malposition, inclination, angulation. Okay, now when I say teeth present, it's different from the teeth that you charted previously. For example, in the lower labial segment, you would say missing central incisors, for example, you wouldn't say that all teeth are present. That's it. It's already there in your teeth present chart. Here you would talk about crowding, spacing. If it's mild, moderate, or severe, you will talk about abnormally positioned tooth in terms of if they were displaced buccally or lingually, if they were rotated or abnormally tipped, or of abnormal angulation, inclination. Okay, so you go with the lower labial segment first, lower buccal segment right and left, upper labial segment, and then upper buccal segment right and left. Now I want to examine the teeth in occlusion, in the maximum intercuspation. As I'm doing this, it's important to assess path of closure and mandibular deviation or displacement due to premature contact. So I need to check the centric relations, the centric occlusion. I need to check movement of the mandible. Okay, and then when the patient in the maximum intercuspation, I need to look at the labial segment in order to check the incisors classification, overjet, overbite, center line, and then I look at the buccal segment, and then I assess the molar relationship, canine relationship, any open bite in the posterior segment, or any cross bite affecting the posterior segment. So this is what you need to record in your examination form: incisors classification, overjet, overbite, center line, molar relationship, canine relationship, cross bite, if present. So just to remind you, the incisors classification is based on the relationship between the lower incisor and the cingulum plateau of the upper. So this is a class 1, class 2, division 1, class 2, division 2, and then you have here the class 3 incisors classification. So this is obviously class 2, division 2. This patient here has class 1 incisors classification. This patient has class 3 because the lower incisal edge occludes anterior to the cingulum plateau. And here you have a class 2 division 1 incisors classification. The overjet, as you know, is the horizontal relationship between the upper and the lower incisors, and it is measured from the upper labial surface to the lower labial surface. And on average, it should be 2 to 4 millimeters. And when we measure it, our ruler has to be parallel to the occlusal plane, and it has to be perpendicular to the line of the arch and to the labial surface of the incisor that we are measuring the overjet at. So we go to all incisors one by one and we measure the overjet, and then we record the worst overjet, okay? The highest, let's say. And if it's totally different from one incisor to the other, then you can record the overjet on each individual area, okay? You don't have to be confused and only pick one if it's really variable between teeth. This is how you measure it. So from the labial surface of the upper to the labial surface of the lower. So this is a 1, 2, 3, 4 millimeter positive overjet. And here is a patient with an anterior crossbite. So it's the same from the lower incisor labial surface to the upper incisor labial surface. 1, 2, 3, 4. So this is a -4 negative overjet, reversed overjet. Okay. So this is a patient with a class 2 division 1 incisors classification and increased overjet. This is at least 8 to 9 millimeter of overjet. This is a class 3 incisors classification with a reversed overjet. Now the overbite is the vertical relationship between the upper and the lower incisors. Normally the upper incisor should cover 1/3 of the lower incisors. If we have a positive overbite, that means we have some vertical overlap between the upper and the lower incisors. We need to describe 4 things on your examination sheet. Number 1, is this overbite average or reduced or increased? Is this overbite complete? Do we have a contact between the upper and the lower teeth? Complete or incomplete? Number 3, if it's complete, is it complete to soft tissues or to hard tissues? And number 4, is it traumatic or atraumatic? Okay. Now, as we said, normally the upper incisor should cover 1/3 of the lower incisors. If it covers more, then this is increased. If it covers less, then this is a reduced overbite. If we have a total lack of overlap, what we call open bite, we still need to describe this open bite, but different features are necessary to be recorded. So if I have an open bite, there are 3 things I need to talk about. Number 1, how much is the open bite? 3, 4, 5 millimeters, so we need to measure it. Number 2, is it symmetrical open bite affecting all the labial segment or asymmetrical? And number 3, from which tooth to which tooth? So it's extension from where to where. Okay, right. So as we said, if overbite, we need to say if it's increased, reduced, or average, complete, incomplete, soft tissue or hard tissue, traumatic or atraumatic. So as you can see here, this is an example of a deep, complete overbite. Increased. When I say deep, it means an increased overbite. This is an example of an average overbite. And this is an example of a reduced overbite. So the upper incisors are covering just about the incisal edge. So this is a reduced overbite. This is an example of an anterior open bite. Okay, so this is an anterior open bite of about 4 millimeters, and it is asymmetrical, and it extends from the 4 to the let's say 4 on the other side. Okay, these are retained Cs. And this is a posterior open bite. This is a posterior open bite. So this is a patient with a class 2 division 1 incisors classification, increased overjet. Overbite is increased, complete, and traumatic. How do we know it's traumatic? Because the lower incisors are in touch with the palate. And as you can see here, we have gingival recession and indentation of the lower incisal edges. Central line should be assessed looking at the upper central line in comparison to the central line of the face. So if we look at this patient here, we ask her to smile, we look at the central line, you can see that the upper central line is shifted to the left about 2 millimeters. And then we compare the upper central line with the lower. So you can see that the lower central line is within the central line of the face, but the upper central line is shifted to the right, 2 millimeters, shifted to the right. Now, molar relationship is the relationship between the upper and the lower first permanent molars, where the mesobuccal cusp of the upper should occlude in the buccal groove. So this is a class 1. This is a full unit class 2. And this is a full unit class 3 molar relationship. The canine here is almost class 1. It's almost quarter unit class 2 here. And here is a little bit difficult. This is the canine, and this is the canine in the lower. Now, for this canine to be called class 1, it should be occlude here in the embrasure between the lower canine and the fore, but it has jumped 1 whole cusp and a half. Okay, so this is what we call 1.5 class 3 canine relationship. Crossbite is to describe the discrepancy in the buccolingual relationship between the upper and the lower teeth. Buccolingual also applies to labiolingual or labiopalatal, okay? So this means that this could apply to the anterior teeth or to the buccal segment, the same, or the posterior teeth, okay? So crossbite is the discrepancy in the buccolingual relationship between the upper and the lower incisors, and it should be classified into anterior crossbite or posterior, or maybe both. Which teeth are included in this crossbite? Is it a localized crossbite, or is it a generalized crossbite? Most importantly, is it with or without mandibular displacement? And if it's in the posterior segment, is it lingual crossbite, or is it buccal crossbite? Is it unilateral or bilateral crossbite? So all these are things that we need to use to classify and to describe the crossbite, okay? And this table will tell you the difference between the buccal crossbite and the lingual crossbite. A displacement of the mandible is extremely important to be detected as soon as you realize that the patient has a crossbite. So every crossbite is associated with mandibular displacement unless is proven otherwise. So if you have a crossbite, you need to check centric relation, centric occlusion. If there is any premature contact, any mandibular displacement, this mandibular displacement could be to the anterior, this mandibular displacement could be to the lateral side, maybe to the left, maybe to the right. So it's very important to look at any signs of mandibular displacement if you have crossbite. Why is this important? Because this is a functional shift. It will affect the temporomandibular joint, and it should have a priority for treatment in general, and it will affect the occlusion that you are examining, right? Because your treatment and your assessment for this patient should be based on the centric retruded position, centric relation. So this is an example of a patient with normal buccolingual relationship anteriorly and posteriorly, no crossbite. This is an example of a patient with a unilateral buccal crossbite on the left side. And as you can see, with mandibular displacement, because this is the centric relation. Central lines are coincident. We have a potential crossbite on both sides. And then when the patient bites his teeth together, it will be shifted, the mandible will be shifting to the left. And then we will end up with a crossbite on the upper left 6, 5, and lateral on the same side. Okay, so this is a unilateral buccal crossbite with mandibular displacement and an anterior crossbite on the upper left lateral. This is an example of a lingual crossbite that is affecting only one tooth. And this is the assessment form where you have to write down all the things that we talked about in terms of the incisors classification, in terms of overjet in millimeters, overbites, as we said, the 4 things that we need to mention. Molar relationship, it's important to mention the right and the left. And if it's a class 2 or class 3, it's important to say if it's a full unit, half unit, quarter unit. We don't say class 3 only or class 2 only. You have to specify how many units. The same for the canine relationship. And then crossbite, you have to describe the crossbite exactly like we said, and then the central line, the upper and the lower central line in comparison to the central line of the face. So this is finishing the clinical examination. Once you've done your thorough clinical examination, sometimes you need some diagnostic records in order to aid diagnosis and treatment planning, to monitor growth, to monitor treatment, for medical legal record, for patients' communication and education, especially in patients with multidisciplinary treatment necessary, audit and research in big centers and big hospitals. Examples of the special investigations and diagnostic records, study models, photographs, radiographs. The study models are taken by having an alternate impression for the upper and the lower, and we take a bite, and then we pour it with stone. And then we trim it using a technique known as angle trimming. We trim it in a way so that when we position the cast on the table, then we can examine the occlusion accurately in varying angles. Okay. The other alternative is to have an immediate intraoral scan, and then you can have the digital study models. Sometimes you take the impression and you pour the stone, and then you send the study models for a 3D laser scanner. And then you don't need to keep the stones, and you can just have your digital records, which is easier easier for you to communicate with your colleagues, with the patient, to show them on the screen, etc. Photographs. According to your textbook, there are the 4 basic extraoral photographs: the full facial frontal at rest, the full facial frontal smiling, and then the facial 3/4, what we call the oblique view, and then the facial profile. For us, we take 6 views. We take frontal rest, frontal smile, profile rest, profile smile, and then oblique rest, oblique smile. Okay, especially for patients that needs a comprehensive examination, who present with syndromes or skeletal discrepancy, or who we're planning for orthodontic surgery. Intraorally, we have 5 basic views. We have the frontal occlusion, the buccal occlusion, left and right, and then the occlusal views for the upper and the lower arches. So this is the buccal view on the right side, frontal view, and then buccal view on the left side, and then you have the upper occlusion and then the lower occlusion. Radiographs, of course, not every patient we should order a radiograph for. We need to have a proper and comprehensive clinical examination. And if we need to aid to our information and diagnosis, then we take a radiograph. So there's nothing called this is a basic screening for the patients, okay? But if you are planning to start orthodontic treatment and active orthodontic movement, then you have to have an OPG at least in order to check for any pathology undetected, because you're going to be moving teeth in bone, okay? But if it's just a quick consultation, check on the occlusion, everything you see is normal, then you don't need to take radiographs. We need to follow the ALARA rule, as low as reasonably achievable. And if you take a radiograph, then it's important to look for the presence or absence of teeth, the stage of development, of course, of the permanent dentition, because now I can see the roots. The root morphology, including the root length or any existing root resorption, presence of ectopic or supernumerary teeth, presence of dental disease, relationship of the teeth in the skeletal dental bases, and their relationship to the cranial base. And this is in specific for the lateral cephalogram. So the common radiographs that we use for orthodontic assessment, we have the DPT, dental panoramic tomograph, cephalometric lateral skull radiograph, upper standard occlusal radiograph, periapical radiographs, and rarely bite wings. Okay. So this is an example of views that were taken where we detected some supernumerary teeth unexpectedly, because clinically this wasn't expected, but because we are planning for orthodontic treatment, you could see that the presence of supernumerary was very important. This is a case where we had supernumerary, we requested its extraction, only part of it was extracted, and then we noticed a swelling, and we had to take another one, and we discovered that one of the supernumeraries were taken and the other one was left there. So we sent the patient again for extraction. We were lucky that we didn't have any root resorption. Right. The DBT, if taken, this is very useful to confirm the presence, position, and morphology of unerupted teeth, and general overview of the teeth and their supporting structures, and the roots morphology as well. If you need further information for the incisor region, this is not the view to be taken, or you can have you can aid your view by having an upper occlusal or periapical. And it should only taken if you in the presence of specific signs and symptoms. This is not a standard screening for every patient. You need to have a proper clinical examination and then have a good reason to take a radiograph. This is an anterior-posterior cephalogram taken because the patient was presented with facial asymmetry and we had to go for a proper assessment. The patient also has a skeletal problem, the anterior-posterior dimension, with a class 3 skeletal relationship. So we had to take a lateral cephalogram. The upper occlusal is usually taken to check for the upper labial segment or position of impacted teeth or root condition, etc. Periapical are taken in order to aid the clinical examination for small areas. For example, if a patient had a trauma, then we can assess the root position, length, and condition before any active treatment could be taken. Also, it can be used in order to assess the technique used to localize impacted teeth, but the parallax technique. Okay, we have vertical and horizontal parallax technique using two views by changing the direction of taking the radiograph of about 20 to 30 degrees minimum in order to have an effect. As you know, the slope technique, same is lingual, and opposite is buccal. So slope technique is used to localize impacted teeth. Beam computed tomography, although nowadays it's of course faster and less radiation exposure than the conventional CT scan, yet we only order it if we need further information regarding an impacted tooth, patient with a cleft lip and palate, pathology, resorption of teeth, syndromic patients, etc. A patient who we want to plan orthodontic surgery, for example, we can take these views. And it will give you an accurate location of the impacted teeth and assessment of any associated pathology, especially the root condition of the adjacent teeth. And of course, assessment of alveolar bone coverage of teeth, cleft palate if the patient is having a cleft, assessment of alveolar bone height and volume in case you're planning for an implant, temporomandibular joint or airway analysis, and planning of some complex combined orthodontics and orthodontic surgery cases. So for example, if I'm planning for bodily movement of the buccal segment and expansion, it's important to check if there is enough buccal bone covering the roots. Otherwise, you will end up with fenestration. You will end up moving the teeth in the air. So it depends on what you are planning, and then you can justify taking such a view. Again, although the radiation dose is considerably smaller than the conventional CT, but the dose is still higher than the conventional radiographs that we take. So if the conventional radiographs is not expected to give you enough information, then we can order a Combian CT scan. 3D imaging is not only radiographs. We can have optical laser scanning and stereophotogrammy for photographs, as we said, and for digital study models. So this is finishing the history, the examination, and we collected these records. We collect all these sources of information, we analyze them properly, and then we reach our diagnosis and problem list. Once this is done properly and accurately, then you can have a proper planning for the treatment for your patient, and you will have a good management for your patient. So this is finishing the orthodontic assessment. Thank you for listening.